Hi, everybody. Um, Thanks again for watching the video. We're going to go through another ECG today. Just want to apologize. I know we've been having a lot of ECGs recently. That's my fault, unfortunately, due to illness. I've been struggling to come up with some new presentations. So I've started digging into the archives of some of our ECGs that we hadn't done and had planned to do over the next few months. But this is actually quite a nice one. Not too difficult. Quite simple when you really look at it, and something that will just take a bit of logic for you to figure out, but something that we can all learn from, especially those of us who work in sometimes resource restricted environments where we don't have labs and things like that. Then this is actually one that you would enjoy. All right, so let's try and get into it. So what we have this week is a 20-year-old pregnant woman with 12 hours of persistent nausea and vomiting. And we're going to go through our normal breakdown where we analyze the axis, the rhythm, all the components of the rhythm, the rate, and then we're going to analyze each zone and see what abnormalities we can find. Now, as I always tell you guys, you've got to imagine yourself as being on the way to see this patient. Imagine you've just gone to lie down and you're working in an emergency center, or you're working in a maternity ward, or whatever it may be, and you get a call from the nurse and she says, listen, we've got this patient not looking too well, she's dehydrated, she's got hyperemesis, and you decide, okay, I'm going to come through and I'm going to have a look at her. And what's immediately on your mind? Well, I mean, 12 hours of nausea and vomiting, it is hyperemesis, that's for sure. Hyperemesis gravidarum, and it does depend on which trimester the patient is in. That will also help you to make your diagnosis. I'm guessing this is going to be a first trimester patient just based on the ECG, but that's another story. And as you get later on, and as you get eclamptic patients, and especially those where the intracranial pressure is rising, they can also present with persistent vomiting. Those in the second trimester, it's less common for it to happen. And you'd actually look outside of the pregnancy for causes of nausea and vomiting. The majority of those who do have extended periods of hyperemesis, generally it's from the first trimester carried over into the second trimester. It's very uncommon for hyperemesis to start in the second trimester. It does happen, but it's not common. All right. So you've got to start thinking now, what's going to happen to a patient who's been vomiting for that long? And just take the pregnancy out of your mind. The pregnancy is the cause of the vomiting, but let's take it as any patient who's been vomiting persistently for 12 hours. All right. What are you worried about? So the first thing, of course, is dehydration. Patients are unable to get anything in, so they're taking everything out. So they are going to get dehydrated. They are at a greater level of fluid loss than fluid intake. All right. So you've got to consider dehydration and all its ramifications with that. What else are you worried about? Electrolyte abnormalities will also come into it because you're losing a large amount of hydrogen ion. So you're becoming more and more alkalotic. And what are you going to do to try and counteract that? So you'll often find these patients are bradypneic, the heart rate slows down, urine output decreases. There's quite a few things that happen. And as you become more and more alkalotic, level of consciousness decreases. There's quite a few things that happen, okay? Sodium levels go up because of intravascular dehydration. So there's a lot of things that you have to consider from there. And then, of course, you've got your hemodynamic instability. Your patient can be in hypovolemic shock, so you've got to think of that as well. There's the cardiac ramifications. So you've got to start thinking about all of these things. Now, of course, when you see the patient in front of you, if you have a patient who's GCS 15 over 15, mildly dehydrated, you'll probably do a blood gas, basic blood, start rehydration, and of course, an antiemetic and things like that. And the majority of your patients will respond, Yeah, so these are all the things that you would consider when you are seeing this patient. And so, like I say, and of course, if your patient is, has a decreased level of consciousness, has, advanced dehydration, severe dehydration, moderate to severe, has cardiac arrhythmias, whatever it may be, of course, you're going to start to look at doing more intensive investigations. And that's when ECG would probably come in. So we can assume this patient is actually quite sick if we have gotten to the point where we are doing be an ECG. Now, if in a resource-rich environment, you would do an ECG on each of these patients. You would do an ECG on every single patient that walks through your emergency department. Those of us in resource staff, we know it's not always possible. And so let's have a look at our sorry, let me just get all of this up. All right, so let's have a look first at our axis. All right, so let's pull this here. All right, so we know we've got lead 1, and we've got lead AVF here at the bottom. All right, so let's have a look and see. So we've got lead 1, that's positive. You can see it's pointing upwards, so that means that your axis is actually either normal or towards the left. Right? Okay, so let's just put you, so it's either normal, okay, so N for normal, left, oh, sorry, I'm trying to think, I'm just writing, so left, let's just put here extreme right. Okay.
This week I'm in a ward, but next week I'm in a clinic.
So let's just put extreme right. I'll try and do it as best as I can. And right. Okay.
No.
Okay, so those are our axes that we can get, right? So because the lead 1 is pointing upwards, so we know it's either left or normal, right? So we go to lead AVF, and you see lead AVF is also pointing upwards. So that means that, let's put this in a different color. So if we just take lead AVF, so that means the electricity is moving towards him. If anybody is a bit confused about this, just remember that we've got the what you call the videos on how we work this out. All right, so we can see that it's definitely, I think I picked the wrong color. Let's just use pink color. All right, so we can see that it's definitely not left. So we've got a normal axis. Okay, so that's the first thing that we can take. All right, so let's have a look at the rhythm. So we start looking first at our P waves. So we notice our P waves are relatively normal, maybe a bit shallow, but that can depend on axis as well. And in a pregnant lady with the increased intravascular volume, it can sometimes cause atrial shift, which can also change your atrial axis. But that's a bit more advanced. You don't need to stress about that. So if you look, we've got 1, 2, 2.5 to almost 3. So we've got a normal P wave and PR interval. We've got narrow QRS complexes. We've got a QRS following every P, and we've got them coming in relatively regular intervals. All right. So again, if anybody's lost, just go back and watch that video. All right. Let's look at our rate. So we've got 1, 2, 3, 4, 5, 6. So 300 divided by 6. You're looking at about 50. So that's quite low for a pregnant patient. So this is where we need to get worried. She's becoming a bit bradycardic. So once you get bradycardia, you've got to start thinking about what would cause the heart to slow down. And the other thing that we don't normally concentrate on, but I want you guys to have a look at, we have had a look at it before, is your QT interval. Now, in this particular patient, just eyeballing it, the QT is prolonged. All right. Now, if you have a look at the top of most of your ECGs, you'll have QT and QTC. That's the measured QT and the QT corrected. It's corrected according to the rate as well, right? So you've got to look at about 450 as a maximum for males and about 460 for females. So if you had to calculate this, and it's quite a complex formula, if you have a chance, you can watch the video that we did on it, but you'd see it would come out to just above 460. It's coming out to about 470 or 480 on this patient. So once you've got QT prolongation and you've got bradycardia, the first thing you've got to start thinking of is all the hypos. So hypokalemia, hyponatremia, hypocalcemia, hypomagnesemia, all of the hypos start coming into play, and it kind of matches our history as well of nausea and vomiting, loss of what you would call it acid, H+ ions, and the need to recover those ions. So we start losing potassium in the kidney, we start losing calcium in the kidney in order to bring in hydrogen. Now, if you guys are a bit lost by all of that, what I would suggest is have a look online. You'll actually get the UCT Chempath book. I must actually see if I have it and release it on the group. And it gives you a good breakdown of renal pathology and renal chemical pathology. And it's something everybody should have a look at. So I'll see if I've got it and I'll put it on there. Okay, so let's look at each zone. All right, so we look at 2, 3, and AVF. Besides our QT interval, the one thing we notice is these little Q waves. Now, these are not abnormal. Again, it depends on the axis and the exact axis and the fluid dilatation and things like that. But it is a bit worrying, all right? You shouldn't really have Q waves over here, but even though these are not pathological, they are worrying. Okay. And then let's have a look at AVR. So in AVR, we don't see much. It looks like a normal AVR and it's fine. If you look at, well, let's look at the lateral leads maybe, the high lateral leads, leads 1 and AVR. The main thing that we notice is the deep S in lead AVR, which is not normally seen there. We normally have something similar to lead 1. So it could be due to placement of the lead, or it can be, as we say, due to this intravascular dilation that normally takes, ventricular dilatation that takes place during pregnancy. Okay, now if you look at lead V1 and V2, which are your septal leads, the first thing you notice is these deep S complexes, all right, which again point to ventricular dilatation, not necessarily hypertrophy, although in this case it could also be due to hypertrophy if you really calculate it out. The one thing that is a bit abnormal though is if you consider this little formation over here on the T wave. So a biphasic T wave is always something to worry about. It's not something you should just take lightly. So biphasic T waves, especially like this, where it's down and up, down and up normally represents hypokalemia, all right? And up and down normally represents something we call Wellens syndrome, which is a cardiac marker for which was sudden cardiac death and cardiac arrhythmias. But so that's down, up. The first one is up and then it goes down. That's biphasic. And in this case, it's down and up, which is normally indicative of hypokalemia, which is again fitting in with our diagnosis that we've come through so far. And then if you look at V3 and V4, we start seeing slight ST depressions along with QT prolongation and a bit of this biphasic T wave as well, right? So all of this is starting to take us closer and closer to hypokalemia, because hypokalemia also causes ST depressions as well. Okay, QT prolongation and biphasic T waves, especially in these V2, V3, V4, but it can occur in any, but it's more common here, all right? So we're starting to get towards this diagnosis of hypokalemia, and we've also got evidence of left ventricular hypertrophy or high dilatation consistent with pregnancy. And then if you look at V5, V6, which are your lateral leads, and we've already looked at one in AVL, again, we can see the QT prolongation. We can see the slide at the end, but that's not something we're going to cover right now. We'll cover it in a later lesson. Okay, so this is all leading us towards hypokalemia, and I think you know where I'm going with this. This is a case of hypokalemia. Okay, so we had everything worked out up till there. So let's look at your typical ECG findings associated with hypokalemia, U waves, which we're going to have a look at now, ventricular ectopy, which we didn't see here. So ventricular ectopy would be a QRS complex without a P wave that just suddenly pops up out of nowhere, all right? So it's not an atrial ectopy it's just a straight ventricular ectopy. ST segment depression, which we had seen, T wave flattening, which can occur, and I'll show you other types of T waves that you get. And the T wave is actually the most common one, right? So in this author's experience, we've taken this from ECG for emergency physicians. Moderate to severe hypokalemia often induces an unusual biphasic T wave in the mid-precordial lead. So V3, V4, V1, the ST segment sags downward. So that's what we're seeing over here. As compared to a proper ST depression, where you would get the S wave coming here and then a depression, we see it's just slowly sagging off, you know, as compared to a proper depression, which you may see in NSTEMIs and things like that. It can produce ST segment depression and then rise into an upright T wave with slightly prolonged overall QT interval, which we had here for about 470. It may be that this upright T wave is actually a U wave following an inverted T wave. So that's getting a bit into the weeds, but it's basically them describing this down-up pattern that I discussed with you guys. So what they're saying is that that's a T wave and that's a U wave, but we'll talk about U waves a bit just now, right? Regardless, the biphasic complex is characteristics of hypokalemia and normally resolves with appropriate treatment. Patient's serum levels were low, and the biphasic T wave of hypokalemia should not be confused with the biphasic T wave of Wellens syndrome, which, like I told you, it's the opposite. It's up and down as compared to down and up. Okay, so they are mirror images of one another. So let's have a look at what are your common findings. So you would normally get a prolonged PR interval, slightly peaked P wave, and I think if we go back, we might actually see the slight peak. Yeah, we can actually see the slight peak in the P waves here, although we don't have a PR elongation, so that's something else that we need to get. And ST depression, but like he said, it's a sagging depression rather than depression that goes like that. So let's just put what a normal ST depression may look like. So if you are looking at a normal, sorry, let me get this here. So if we are looking at a normal ST depression, we'd see the S wave continue down there, and then we'd see something like that. So that's what a normal ST depression, as compared to this one that starts off and then just sags down to give us that picture that we're seeing there. So shallow T waves as well, which are quite common. You can get QRS flattening as well. And it's, even though it's not indicated here, it can happen sometimes. You get these shallow QRS complexes. In our case, we didn't because of the physiological adaptation of pregnancy, and then a prominent U wave. Now I'm going to show you the different types of U waves in a second. Okay, so these are the common things, and if you take nothing else away, just take this away from it. All right, so these are the common findings. And like I say, let's say you're in an area your blood gas is not working, you don't have access to a UNE. Just by finding these, you can actually start treating the patient based on those findings. So these are your U waves that you can see in hypokalemia. Now, one of the ways that they describe it is like a camel's hump. So here we see what you would call it. The ST is not depressed, but we see an inverted T wave and a U wave. All right, so it gives us typical camel's hump, and these are all the different types that you may get. Right, so it can become shallower, can be more peaked, and generally the more peaked and the more higher the U wave and the more flatter the T wave and the greater the QT prolongation, which you can see here too, the worse your hypokalemia is. All right, so I wish I had kept that ECG, but we had a patient who had a rectal prolapse and was leaching potassium from there on an amazing basis, and his actually was completely flat. So we had a T wave that would probably start from about there, and we had a U wave that would also just go from there, and a QT that had been prolonged to over 500. So it was closer to about there. And regardless of how much potassium we gave him, he would keep on leaching out. Ended up in our ICU and only resolved after a rectoplexy, which is where they reduced the rectum, and it prevented any more leaching. But he was going through, I think, about 60 to 100 milliequals a day. So that's about 5 vials of potassium chloride a day. And he was still hypokalemic. So it just shows you how bad it can be sometimes. Okay, and that's just a little joke to finish off. My wife loves this one because she was like this when she was pregnant. But anyway, I hope you guys enjoyed it, and I'll have a look for that book as well, and I'll put it on for you guys so that you can have a look and see. Another thing that I would advise you to look at is learn about renal tubular acidosis, because it's a very common diagnosis in South Africa because of a high rate of diabetes and hypertension. So we have a lot of renal tubular disease. So what I would suggest, I mean, you should know ChemPath in any case, but what I would say a takeaway from this is probably look at the renal losses that occur and the renal reasons for or how renal exchange occurs. It's something that will serve you well for the rest of your career. Okay, thanks a lot, everybody. And if you have any questions, please don't feel shy to let me know. Thanks. Bye.